Good morning. My name is Claudine, and I am Dr. Lee the GP, and I'm coming to you this morning from my garden, which is a beautiful, peaceful place. And I'm dedicating these talks to the many patients who I've been in partnership with, the many diabetics over the years. And in particular, this talk is dedicated to a very inspirational pilot, a type 1 patient who gave a talk at CDE last year. It came home to me when he was talking at how we just do bandy about concepts like basal and bolus, especially when you're newly diagnosed, and it doesn't always make sense. So these talks are a dedication to patients who I've worked with, but they're also hopefully going to help newly diagnosed patients and just make it a little bit easier to understand when you very much on the beginning of the path of being a diabetic patient. So, what is basal and what is bolus? And when we're talking about these concepts, we're talking about them in context of insulin. Before we go into some meaty substance, it's not a long talk, but it can be something that could be overwhelming, and I always think we should slow down and breathe. So I invite you to breathe in slowly for 4 counts and breathe out for 8 counts. And do this in your own time and do 3 rounds of this breathing. So what are the body's requirements? Every single human cell requires glucose in order to function. And the only way that the glucose can get into the cell is using insulin. Insulin, so to speak, is the key that allows the glucose to go into the cell. I want to put it in a way that maybe other people don't put it, but the only way the cell can actually swallow the glucose it needs is with the help of insulin. Insulin unlocks, so to speak, the key to the cell wall to allow that glucose molecule to get into the cell. And without the glucose molecule, the cell, so to speak, cannot perform its functions. And obviously each cell has a different function, but every single cell in the body, from a brain cell to a heart cell to a skin cell, requires glucose to do what it needs to do. So basal insulin, if we're looking at a definition, is the sort of the base or the foundation insulin that one requires in the background to be running. It is the minimal amount of insulin that is required to be in the background for all of these things to happen on an ongoing basis, on a minute-to-minute basis. So if you look at this graph, you can see the bottom sort of orange-yellow layer, basal insulin, where it says basal insulin, and in this case they used glargine, is that basal bottom layer of insulin. In other words, when you inject your 10 units of opticillin or your 20 units of Levemir or your 15 units of Tresiba, whichever long-acting insulin you're using, you inject it usually once a day if you're using analog insulin, and that creates a layer, a basal layer of insulin for all your background requirements for the cells that are needing the glucose. I'm not going to go into the rest of this graph right now, but what I want you to try and see is that basal layer. And what we want in an ideal world is for that to be as flat as possible. In other words, no peaks and troughs on your basal layer. We're now going to move on to bolus. Okay, so what is a medical bolus? It is a dose of a substance such as a drug given intravenously. Now, in this case, we give insulin subcutaneously. So it is a dose of a substance given by injection, the purpose of rapidly achieving a therapeutically needed concentration in the bloodstream. Okay, so when we give a bolus of insulin, we're either trying to correct a high sugar or we're trying to cover a meal. So we give boluses at meal times. So one needs to have an idea of how much carbohydrate we are wanting to cover with a bolus. And this is a bit of a learning process. It is complicated by different people weighing different amounts, having different needs, processing glucose in a different way. You can be either very sensitive to insulin or you can be quite resistant to insulin. And depending on many, many factors, makes a difference to how much of a bolus or how little of a bolus you would require in order to cover your meal. So insulin sensitivity not only is affected by the things I've already mentioned, but it is also affected by time differences. In other words, if you're traveling, if you're jet lagged, that kind of thing. Hormonal fluctuations, in other words, where you are in relation, if you're a woman, in relation to your menstrual cycle. Also, if you're going through puberty or something like menopause, it affects the insulin sensitivity. The weather plays a role, as well as the altitude, and then there are many other factors that affect insulin sensitivity. So if we're doing a bolus in relation to a meal, we only want to bolus for the carbs that we are taking into the body. So these need to be counted or estimated, taking that sensitivity into account. So some people require a lot more insulin in the morning with breakfast, for argument's sake, compared to what they require in the evening. Some people use one dose or one sort of ratio when they're calculating their bolus. That's a very individual type of a thing. But when we are injecting for a mealtime, we want to try and work out what is the individual sensitivity and what numbers are we working with. So for argument's sake, are we injecting 1 unit for 15 grams of a carb, 1 unit for 1 slice of bread, or am I the type of patient that requires 2 or 3 units for 1 slice of bread? Obviously, children require a lot less. So some children, for argument's sake, might only require half a unit for a slice of bread. But one needs to look at the plate of food that one is about to eat and look at all the carbs on that plate and try and estimate or count the value and then try and get an idea of how much one needs to inject for this meal. Patients do get into the habit of injecting exactly the same amount of insulin for every single meal, but we're often eating very different amounts, and we're often eating very different amounts of carbs. So what is a carb? Okay. Fruit, bread, pasta, rice, potatoes, even things like mealie has some carb in it. So there is some crossover between some vegetables, which some people, some veggies are free, so to speak, but some vegetables like a potato is also considered a vegetable. It is very carb heavy, so to speak, and pushes the sugar up really, really high unless you are matching it with the amount of insulin that you're injecting. So not everybody is aware that fruit are carbs, and fruit is a very healthy thing to eat, but one needs to factor in. So any food that breaks down either to a glucose molecule, a fructose molecule, or a sucrose molecule needs to be covered by your short-acting insulin bolus. You don't want these extra molecules of sugar to hang around in the bloodstream because that causes high sugars. And as we know, Sugar is sticky. So as I often say to my patients, if you pour Coke on the floor and then you stand on it, it's a sticky mess. Whenever your blood sugar is above 10 in your bloodstream, it is a sticky mess inside of those blood vessels. And if you think about your eyes and your kidneys and your brain and these tiny little blood vessels, when it's a sticky mess like that, it causes complications with your vascular system. And that's where the complications come in. And over a long period of time, particularly in the eyes, that's where the damage is caused. So this is just a very short explanation of basal and bolus. And if you've liked this, I'm going to be doing short little talks about other aspects of diabetes. And I encourage you now, if you've got time and space, to take a moment for yourself. And I encourage you to try this pose. It's called child's pose, and it's a deeply relaxing pose to the central nervous system. And you can either do it with your arms out in front of you or with your arms to the back. And just do those same deep breaths of 4 breaths in and 8 breaths out. And even just do it for a minute or two. You'll find that this will actually reset you, charge you up with a little bit of energy, calm your nervous system, and you can continue with your day.